Good evening, Director. I'm here at Hipkins Hospital to propose some process improvements to increase the number of surgeries complete while reducing patient flow times. I will start with an overview of the HipOp case and then review my recommendations and analysis using pooling, variance, and psychology, then a conclusion of my analysis. The goal here is to increase the numbers of surgeries completed per day to 6 or more while decreasing the patient flow times. The surgery workflow is a continuous flow of surgical procedures being carried out in an orderly manner. There are currently 4 operating rooms that have 2 groups, Group A and Group B. 6 patients are scheduled a day with an inter-arrival time of 90 minutes between each patient, with a 9.5-hour workday. If patients are scheduled at the end of the workday, they may need to be bumped to the next day, creating disruption of their arrangements and patient dissatisfaction. This chart shows the total HipOp process and duration for the entire time frame that patients are involved and the steps before and after surgery, to include patient registration, pre-op prep, anesthesiology, eval and consent, procedure, room turnover and setup, recovery, and discharge. An important factor to procedure time is the parameters based on a patient's BMI. There is a large percentage of obese patients and morbidly obese patients, which is leading to a longer procedure time. With 4 operating rooms that are divided into groups A and B, the pre-arrival time of 90 minutes between patients, there is 1 anesthesiologist and 1 surgeon per OR room. The patients are randomly assigned into rooms with no separation, causing an increased variance and standard deviation. The mean procedure time is 100.71 minutes, with a standard deviation of 8.09. Only 4 surgeries completed with 83.6 patient flow time. To optimize the number of surgeries per day while decreasing patient flow times, I'm recommending that Hipkins Hospital maintains 4 operating rooms that have 2 groups. The groups will be divided by their BMI to decrease the variance and be able to allocate enough time for the procedures of their group. Group A will take patients with lower BMIs, such as underweight, normal, and overweight, and a percentage of the obese patients. Group B will include the higher BMI patients to include mostly obese and morbidly obese patients. We are also recommending that another surgeon and anesthesiologist are added so a total of 4 surgeries can be going on at any given time. Through eliminating the registration process, you can save 5 minutes per patient, and this can be done online prior to arriving or through AI help. We are recommending to keep the same pre-arrival time of 90 minutes for Group A and Group B, and if resources are available, then adding another EVS staff member to clean and restock faster that will allow them to finish prior to the next surgery. This is my recommended discrete event simulation model to support my analysis. Here, there are 4 operating rooms divided by 2 groups based on BMI. Group A's patients have a mean of 96 minutes for surgery time with a standard deviation of 6.79 for a new patient flow time of 118.12 minutes. Group B patients would have a mean of 100 minutes for surgery time with a standard deviation of 13.42. In this case, utilization matters and contributes to the main success of the HipOp case. Most of the bottlenecks are occurring where the anesthesiologists and surgeons are being overutilized. This is why the hospital wasn't able to complete more than 6 surgeries per day. The discrete event simulation model demonstrates that utilization can help increase the total number of surgeries to almost 5 for Group A and 5 surgeries per day for Group B. No registrar needs to be added since 2 is enough in the current state. However, one recommendation is to have no registrars and complete this process completely online. Through adding 2 anesthesiologists to the groups, you can achieve more surgeries per day as patients can be sedated at the same time. With 2 surgeons, you can have 4 active surgeries versus the current state of 2. Finally, with another EVS staff member, cleaning and restocking can occur more quickly between surgeries. There isn't a need to add more ORs as the model demonstrates that another OR doesn't contribute to completing more surgeries or decreasing patient flow times. Pooling didn't work as effectively as I would have liked. Here's a model example where Hipkins could only perform 3 surgeries a day with an increased patient flow time. Pooling is only useful if you can also add utilization or other methods. Pooling cannot be polarized or isolated in the HipOp case, and I wasn't able to pool surgeons as they needed to be assigned to the patients they consulted with originally. While I could pool anesthesiologists, they need to be there the entire surgical process, so this wasn't effective. Variance alone wasn't an effective isolated strategy, but if utilization was added, then the variance decrease would allow for a decreased flow time and increased surgeries completed a day. By unpooling patients, surgery times were able to level out. The perceived wait times are important for patient satisfaction, and there needs to be more time in the procedure itself rather than the prep time to ensure accuracy of procedure and to prevent any revisions that might need to be done. In conclusion, the simulation shows that scheduling more than 6 patients a day is not viable for a teaching hospital that only has a 9.5-hour workday. Only 5 patients a day is the maximum I would recommend, considering the time it takes per patient and remembering the mortality risk given the population of patients. Given that the majority of patients are obese, there needs to be focus on continuing effective training with experienced surgeons. When implementing these recommendations, the numbers of surgeries completed per day would increase while decreasing patient flow times. The surgery workflow is a continuous flow process, and the proposed changes can lead to equity, diversity, and inclusion while reducing bottlenecks in the workflow. Director, thank you for your time.